Good afternoon, everyone. Welcome to today's ACCP Transplant PRN webinar. My name is Allie Webb, and I am a transplant pharmacist at Tampa General Hospital. It is my pleasure to moderate today. Today's webinar will be a recap of the ATC meeting held just last week in Philadelphia. We are honored to have 3 different speakers present for us and very thankful for them to be able to put together some slides so quickly from the meeting and be able to share with us what they learned last week. So I'll give a short bio for each speaker, and then we'll have each one present what they learned. So Layla Jakupovic is a PGY2 pharmacy resident at Henry Ford Hospital in Detroit, Michigan. Dr. Japovic completed her PGY1 residency at the Detroit Medical Center in 2019 and worked as a clinical pharmacist at Henry Ford for 4 years prior to starting her 2nd year of residency. She will be officially joining the transplant team at Henry Ford Hospital in August as a clinical specialist rotating between abdominal and thoracic organ transplant. Following Layla, we'll have Dr. Rao from Boston, Massachusetts, and is the current PGY2 pharmacy resident in solid organ transplant at the University of Colorado Hospital. Madhu will begin work at NYU Langone Health in August as the new clinical pharmacotherapy specialist, focusing on abdominal transplants and working with both inpatient rounding team and outpatient clinic. And then last but not least, we will have Dr. Clemens. Dr. Evan Clemens is an active clinical pharmacist providing direct patient care to thousands of transplant recipients for over 12 years at the University of Washington Medical Center. He rounds with the inpatient transplant surgery team on both liver and kidney subservices, as well as sees patients pre and post-transplant in the ambulatory clinic, and also works in the main inpatient and ICU satellite pharmacies supporting drug distribution activities 25% of the time. So we have a great group of speakers. In a minute, I will turn it over to Layla to begin the presentation, but first, here are just a few quick notes. For our audience members, please ensure your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner. If at any time during the presentation you have a question for the speaker, please submit your question by using the chat functionality at the bottom of your screen. You can send your questions directly to the moderator, to the TXP PRN, and that will help minimize potential interruptions. Please also put in there which speaker your question is for so I can make sure to sort through correctly, and I'll save all questions for the end of the presentation. There will be no CE offered for today's webinar, but we will be posting the webinar to the ACCP Transplant YouTube channel. We are recording. If you experience any technical difficulties during the webinar that are not fixed by logging out and refreshing your internet connection, please make the moderator aware through the chat functionality. Now, without further ado, I will turn it over to Layla Jakupovic.
Thank you, Allie, for the introduction. I'll go ahead and get us started. And I will be focusing on immunosuppression in thoracic transplant. The 5 studies I'll be reviewing are included here on the slide, and we'll go through each one individually. So the first study was a single-center retrospective study out of Mayo Clinic in thoracic transplant patients on the use of non-induction basiliximab to facilitate renal recovery via temporary tacrolimus cessation. The primary outcome was renal recovery at time of tacrolimus reinitiation and renal recovery through day 30. Secondary outcomes included treated infection and rejection. A total of 12 patients were included, consisting primarily of lung transplant recipients, and there were also 2 heart transplant recipients. Basiliximab was considered non-induction if it was given after post-op day 7, and most patients received 2 doses of basiliximab 20 milligrams separated by 3 to 4 days on average. The median time from the onset of acute kidney injury to first basiliximab dose was 5 days, and the median duration of tacrolimus cessation was 6.5 days. So on the left-hand side of this slide, we have a graph of the creatinine trends in the tacrolimus cessation group and in the matched cohort. We see that patients who underwent temporary tacrolimus cessation had higher peak creatinine levels, but similar levels at time of tacrolimus resumption and at 30 days. On the right-hand side of the slide, we have the incidence of renal recovery. So the dark blue is patients that had renal recovery, and the lighter blue is patients with no recovery. We do see that proportionally more patients had renal recovery at the time that tacrolimus was resumed and through 30 days, but this was not statistically significant when compared to the matched cohort. In terms of safety outcomes, there was no significant difference in infection or rejection between the groups, but proportionally more patients were treated for infection in the intervention group. There were 2 patients in the intervention group who also were treated for rejection. Both of these patients were lung transplant recipients with A2 acute cellular rejection. There was no antibody-mediated rejection in either group. There was no antibody-mediated rejection reported in the tacrolimus cessation groups during the study inclusion period. There may have been antibody-mediated rejection in the matched cohort, but I don't have that information. Oh. Okay, sorry, I'm having some issues with the slides. Okay, so to summarize, in this small single center matched cohort study, non-induction basiliximab with temporary tacrolimus cessation in patients with severe AKI resulted in similar outcomes when compared to a matched cohort. Rates of rejection and infection were similar between the 2 groups, and proportionally more infections were observed in the intervention group. Okay, so the second study comes from the University of Colorado Hospital, UC Health, and this was a single center retrospective study comparing the efficacy and safety of belatacept versus everolimus for renal preservation in 93 lung transplant recipients. The primary outcome was a change in GFR at 12 months post-initiation, and secondary outcomes included change in the FEV1, CMV and CLAD outcomes, rejection, change in lipid levels, and incidence of post-transplant diabetes. There were some differences in baseline characteristics, including a higher baseline BMI in the belatacept group compared to the everolimus group, more high-risk CMV mismatches in the everolimus group, and a higher GFR at time of initiation in the everolimus group. Quadruple immunosuppression at time of initiation was more common in the belatacept group. For the primary outcome, there was no significant difference in GFR change at 12 months post-initiation between the groups. And the patients in the belatacept group had significantly higher tacrolimus trough levels at 3 and 6 months, with a median level between 5 and 6, compared to a median level between 2 and 3 in the everolimus group. There was significantly more rejection seen in the everolimus group at 44.3% compared to the belatacept group at 21.9%, and there was no difference in any of the other secondary outcomes. So to summarize this study, tacrolimus levels were significantly lower at all time points in the everolimus group. Both groups had a numerical improvement in GFR, and more acute rejection was seen in the everolimus cohort. Okay, so the third study comes from Duke University Hospital and is a single center retrospective study comparing 2 different de novo mycophenolate dosing regimens in heart transplant recipients. The study was conducted to evaluate the impact of a protocol change from a mycophenolate dose of 1,500 milligrams twice daily to 1,000 milligrams twice daily on transplant outcomes and adverse events. 151 heart transplant recipients were included. The primary outcome was a composite of biopsy-proven acute rejection, graft loss, and mortality within 1 year of transplant. Secondary outcomes included components of the composite outcomes and mycophenolate dose adjustments. There were no significant differences in baseline characteristics between groups seen on the bottom left of the slide. Mean patient age in the study was between 50 and 55 years old, and a majority of the patients were Caucasian males. There was no difference in the primary outcome, which included biopsy of proven acute rejection, graft loss, and death as mentioned at 1 year. This is demonstrated on the Kaplan-Meier curve on the left. For secondary outcomes, the high dose group did have significantly more dose reductions per patient, with a mean of 1.7 compared to 1.2 in the lower dose group. But when dose increases were also included in this, there was a similar number of dose adjustments overall between the 2 groups. So overall, this study found no difference in biopsy-proven acute rejection, graft loss, or mortality with a de novo mycophenolate dosing regimen of 1,500 milligrams twice daily compared with 1,000 milligrams twice daily. There were fewer adverse events necessitating a dose change in the lower dose protocol, and the total number of dose adjustments did not differ between groups when we also included dose increases in that outcome. So the fourth study comes from Cleveland Clinic and is a single center retrospective study to evaluate the clinical efficacy and safety of rabbit antithymocyte-globulin, or rabbit ATG, versus no induction in 190 lung transplant recipients. The primary outcome was the incidence of acute cellular rejection between the rabbit ATG group and no induction group at 1 year post-transplant. Secondary outcomes include the incidence of infection, mortality, and antibody-mediated rejection between the groups, and prescribing strategies of rabbit ATG induction for lung transplant recipients. As for baseline characteristics, patients were 64 years old on average and 63% male in both groups. There was a higher percentage of Caucasian patients in the non-induction group at 91% compared to 78% in the rabbit ATG group. About a third of patients in each group were a primary CMV mismatch, so these were high-risk patients. More patients in the rabbit ATG group required VV ECMO post-transplant, and this was statistically significant, and I highlighted it on the slide. About 10% of patients in the rabbit ATG group had a CPRA that was over 10% compared to just 3% in the non-induction group, but this did not meet statistical significance. And finally, the patients in the rabbit ATG group did have significantly worse renal function at baseline when compared to the non-induction group. For the primary outcome, 36% of patients in the rabbit ATG group experienced at least one episode of acute cellular rejection within 1 year of transplant, compared to 67.8% in the non-induction group. And this was statistically significant after being adjusted for several factors, which included an age under 65, cyclosporin use, female sex, African-American ethnicity, and a CPRA over 10%. For secondary outcomes, more patients did experience infection in the rabbit ATG group, and both the overall incidence of infection and the number of infections per patient were higher in the ATG group. There was less biopsy-proven acute cellular rejection, which included rejection graded A2 or higher in the rabbit ATG group. So this was 17% compared to 38% in the non-induction group. There was no difference in mortality between the groups, but the patients in the rabbit ATG group had a significantly longer ICU and hospital length of stay. So to summarize, patients in the study who received no induction had a higher incidence of acute cellular rejection compared to patients who received rabbit ATG induction. Patients in the rabbit ATG group were more likely to develop infections compared to patients who did not get any induction, and there was no difference in mortality between the two groups. And our last study is from NYU Langone Health. It's actually by it's a single center prospective trial of early conversion to LCP tacrolimus or Envarsus XR in lung transplant recipients. They included 40 lung transplant recipients and compared them to historical matched cohort of patients on immediate release tacrolimus. The primary outcome was freedom from mild acute cellular rejection as defined by ISHLT. Secondary outcomes included the cumulative acute rejection score, rejection requiring augmented immunosuppression, and change in GFR. As for results, there was significantly less ACR or acute cellular rejection in the LCP tacrolimus group compared to the IR tacrolimus group. So 27.5% of patients in the LCP tacro group and 54.2% in the IR tacro group. But this was not statistically, but there was no significant difference in rejection-free survival as demonstrated on the Kaplan-Meier curve on the right. There was also a significant difference in change in GFR between the groups, with the LCP tacro group experiencing a larger reduction in GFR. On average, GFR dropped by 56.2 milliliters per minute in the LCP tacro group compared to 40.3 milliliters per minute in the IR tacro group. And so in this study, we saw similar first-year outcomes between LCP tacrolimus and IR tacrolimus. There was overall less rejection in the LCP tacrolimus group, but it seems that this was a trade-off for a greater decline in kidney function as well. So I think this would be very important to consider when we're thinking about patients who may be candidates for conversion to LCP tacrolimus or Envarsus. Yeah. And that summarizes everything I have. Thank you.
All right, I will be moving on to talk about kidney-related topics. So we will start with this systematic review and meta-analysis of direct oral anticoagulants, or DOACs, in kidney transplant recipients. We know that there are differences among kidney transplant centers with the use of anticoagulation agents. And so the purpose of this systematic literature search was to evaluate the impact of DOACs or NOACs in kidney transplant recipients compared to warfarin. These researchers searched PubMed, Cochrane Library, and MBases, a database up to December 2023, with main outcomes of interest being venous thromboembolism, major bleeding, graft failure, mortality, and changes in estimated glomerular filtration rate. They ended up including 5 studies with a total of 959 patients. Of these, 433 participants, which was just under 50% of the group, were administered DOACs, and the mean age of participants was 60 years old, and about 2/3 were male. In the pooled analysis, the use of DOACs in kidney transplant recipients showed a statistically significant reduction in major bleed, which can be seen in Figure A. The risk ratio was 0.56, with 95% confidence interval 0.35 to 0.9 and a p-value of 0.02. And they also found a statistically significant reduction in mortality, as shown in Figure B, with a risk ratio of 0.49 and a p-value of 0.0006. There was no statistically significant difference found between groups regarding VTE, graft failure, or eGFR, as seen in Figures C, D, and E, and these findings were consistent in sensitivity analysis. Therefore, the ultimate conclusion of the meta-analysis found that DOACs are a safe alternative to warfarin in kidney transplant recipients with lower rates of major bleeding and mortality. Now, moving on, I did go to a session hosted by Natera that reviewed this large retrospective analysis of the prospective observational proactive registry study that was published earlier this year. It is considered to be the largest study of donor-derived cell-free DNA in kidney transplant recipients. As a reminder, donor-derived cell-free DNA has been extensively evaluated as a diagnostic biomarker in solid organ transplant recipients, showing high sensitivity and specificity in the detection of both antibody-mediated rejection and acute cellular rejection, with most of the data being in kidney, heart, and lung transplantation. So the purpose of the proactive study was to evaluate the benefit of using longitudinal donor-derived cell-free DNA testing to help manage kidney transplant recipients in a real-world setting. And specifically, this study's goal was to determine whether this biomarker would be elevated in advance of a diagnosis of rejection with biopsy. So over 4,000 patients were enrolled in the proactive study, as you can see from the image on the right. And of these, 1,631 completed at least 18 months of post-transplant follow-up. 424 had a biopsy, and these were the patients included in the analysis. Among the 424 patients, 60% were male, the median BMI was 28, and the median age was 52 years old. To assess the time frame in which donor-derived cell-free DNA levels were first elevated before biopsy-proven acute rejection compared with non-rejection, donor-derived cell-free DNA tests were stratified by time in months before biopsy, so 1 to 30 days, 31 to 60 days, 61 to 90 days, etc. So this figure on the left here is showing the donor-derived cell-free DNA before biopsy in figure A on the top, and serum creatinine before biopsy in figure B on the bottom. So in patients with antibody-mediated rejection biopsies, shown in the dark blue color, the median donor-derived cell-free DNA fraction was significantly elevated 1 to 5 months before biopsy compared with the non-rejection group. In patients with the T-cell mediated rejection biopsies, shown in the light blue color, the median donor-derived cell-free DNA level was significantly elevated compared with non-rejection groups, both 1 and 2 months before biopsy. In contrast, there were no significant elevations in serum creatinine levels in either the antibody-mediated rejection or T-cell mediated rejection groups compared with the non-rejection groups. And then to elucidate the longitudinal trends for both donor-derived cell-free DNA and serum creatinine, Bayesian multi-level regression modeling was performed using time as a continuous variable and accounting for repeated sampling from patients. And this is what's shown on the graphs A and B on the right of the screen. So as you can see in figure A on the right, before antibody-mediated rejection, donor-derived cell-free DNA levels were consistently increased, trending upward as the biopsy time approached, with an especially stark increase beginning approximately 2 months before T-cell mediated rejection biopsies. And in contrast to the trends in the donor-derived cell-free DNA levels, a rise in serum creatinine levels was observed only shortly before T-cell mediated rejection biopsies, but not before antibody-mediated rejection biopsies, as shown on figure B. And this increase was not statistically significant. And so in summary, donor-derived cell-free DNA fractions were significantly elevated 5 months before AMR biopsies and 2 months before T-cell mediated rejection biopsies, whereas serum creatinine did not discriminate between rejection and non-rejection in advance of concurrent biopsy. And this seems to indicate that donor-derived cell-free DNA can act as an early indicator of biopsy-proven rejection, especially AMR, suggesting that it could have a greater role in surveillance to identify patients at high risk of ongoing or future rejection. And speaking of AMR, results of the phase 2 randomized placebo-controlled trial of the investigational drug felzartamab for AMR were recently published in NEJM and discussed at ATC. So felzartamab is a human IgG1 monoclonal CD38 antibody that works by depleting target cells through antibody-dependent cellular cytotoxicity and phagocytosis. And the purpose of this study was to evaluate the safety and preliminary efficacy in treatment of AMR that occurred at least 6 months after kidney transplantation. In this study, 22 kidney transplant recipients were randomized 1-to-1 to 9 infusions of felzartamab, 16 milligrams per kilogram body weight, or matching placebo. And these patients were about 9 years out of transplant. After week 24, resolution of morphologic antibody-mediated rejection was more frequent with felzartamab, so in 9 of the 11 patients, or 82%, than with placebo, where it was only 20%. For a difference of 62 percentage points and a risk ratio of 0.23. The effect of felzartamab on rejection activity was characterized by a reduction in the microvascular inflammation score with a median score of 0 in the felzartamab group and 2.5 in the placebo group. Changes in morphologic characteristics of allograft were accompanied by a substantially lower molecular score, reflecting the probability of AMR being lower in the felzartamab group than in the placebo group, and that mean difference was negative 0.39. And adverse events reported in all the patients were predominantly mild or moderate in severity. So mild or moderate infusion-related reactions were reported in 8 patients, or 73% of the felzartamab group, but in none of the patients in the placebo group. And the most frequent adverse effects seen were infections, which occurred in 17 of the total 22 patients, and were numerically more frequent in the felzartamab group. So it was 91% versus 64% in the placebo group. The results of this trial essentially suggest that felzartamab may have the potential to effectively and safely reverse ongoing AMR, which underscores its potential as a therapeutic option. And ultimately, the drug did meet its primary outcome of showing safety with promising efficacy, and therefore may be a drug to watch out for in the future. And lastly, use of glucagon-like peptide 1 or GLP-1 receptor agonists and sodium glucose cotransporter 2 or SGLT2 inhibitors in kidney transplant recipients was a pretty hot topic discussed at this year's ATC. I decided to focus in on this single center retrospective analysis reviewed in a rapid fire presentation. So Dr. Rahman and colleagues compared the 12-month safety and tolerability outcomes of GLP-1 agonists and SGLT2 inhibitors in 149 kidney transplant recipients with a median age of 61 years. 74 were in the GLP-1 agonist group and 75 patients were in the SGLT2 group. The median time to start either a GLP-1 receptor agonist or SGLT2 inhibitor following transplantation was 5.8 and 4.6 years respectively, and significantly more GLP-1 agonist users had a history of UTIs. However, both groups had a similar number of patients who experienced UTIs after starting therapy, so 12 patients versus 10 patients. And the median time to the first UTI was 129 days in the GLP-1 agonist group and 261 days in the SGLT2 inhibitor group, and there was a non-significant difference. The number of patients who discontinued treatment did not differ significantly between groups of 15 patients versus 19 patients, and the time to treatment discontinuation was about 130 days in both groups. In both groups, Dr. Rahman and colleagues found no significant changes in magnesium or phosphorus levels and no between-group differences in serum creatinine, hemoglobin A1C, weight, or BMI. Ultimately, the team concluded that GLP-1 agonists and SGLT2 inhibitors have pretty similar safety and tolerability profiles in kidney transplant recipients. Specifically, the SGLT2s were not associated with a greater rate of UTIs or discontinuations compared to GLP-1s in this transplant population that they studied. So overall, there were several exciting findings in kidney transplant recipients shown at ATC, and therefore a lot of potential changes in research to look forward to in the coming years in this population. So I can now pass it on to Dr. Clemens.
Hi, thanks everyone. I'm Evan Clemens from the University of Washington Medical Center, and here's as much info as I could cram into 15 minutes about what I absorbed in infectious diseases and liver transplant at my time at ATC. So I'm a sub-investigator for a couple clinical trials now that none of the therapies are being discussed in this slide presentation, and there's off-label discussion of a lot of therapies as you'll see there on the disclosure slide. So my schedule was jam-packed. I land on Saturday, and this is just like an overview of if you want to know what I did each day. But I was trying to focus on sessions that related to infectious disease. Mainly, that's my kind of area of interest. I was presenting a poster on Saturday on COVID-19 therapeutics in mild to moderate cases in SOT recipients, and so that's what I did on Saturday. And then on Sunday and Monday, I was like 14-hour days, jam-packed with learning. So. Conference themes that I identified in the infectious disease realms, there's a lot of talk about CMV, specifically the role of the newer agents, marivir and letermovir, where they fit in with therapy, discussion about preemptive therapy versus prophylaxis versus hybrid approaches, risk predictions beyond antibodies, and then stewardship of all these new tools. In HCV, I'm kind of specifically focused on this aspect. We've had some issues related to coverage of the TAAs in the post-transplant setting, but there are some papers being presented or abstracts being presented about short duration treatment. So I kind of honed in on those, and I have a slide talking about that. And then respiratory viruses, a hot topic was vaccine responses and strategies, both COVID vaccines, flu vaccines, RSV vaccines, and just vaccination in general was an active area of discussion. And then also, there's several companies developing antibody products, looking at the kind of immune bridging space of, what do you do in people without response to vaccine, or for whom there's no vaccine available. And then liver transplant, I didn't get as much time to look at stuff in liver transplant as I wanted to, because of concurrent presentations going on. But I do have a couple of things to present that I found interesting. So in the CMV space, we of course had letermovir FDA approved last summer, and this is approved for kidney transplant recipients that are high risk for CMV, that are D+ or minus. But this is an expensive therapy. I mean, $7,000 to $9,000 per month, several fold more expensive, like 10 times more expensive than, or more than 10 times more expensive than valganciclovir. So the question is, who is a candidate for this therapy? Who would you put on letermovir as opposed to valganciclovir for prophylaxis? Well, one suggestion at the conference was that, maybe there's a difference based off of age. In one presentation I was in this top right, this Kaplan-Meier curve, you can see they did an SRTR analysis of paired kidneys. And, if you had donor positive kidneys, but then they went into one recipient that was donor or recipient negative and one recipient that was recipient positive, what happened to those people in terms of their survival. And it turns out if it's a young recipient, it didn't make any difference. But once you're over 40, it starts to make a difference, which is interesting. So in the over 40 group and in the older cohort, the curves diverged. And so there's some sort of adverse effect of that mismatch. And I ponder, well, what mediates that difference in older patients? Why are older patients doing worse with these CMV mismatched graphs as opposed to the younger patients? One clue was the sub-analysis of the RCT, presented as a poster, where they looked at the adverse effect rates in older patients over 65 that were getting valganciclovir versus letermovir in this trial. So a sub-analysis of the trial, and in the sub-analysis, the adverse event rates, were higher in both groups, in both the letermovir and the valganciclovir groups, in terms of like neutropenia and leukopenia leading that adverse effects. And the discontinuation rate due to adverse effects was one thing that you might hone in on. And I calculated from this a number needed to treat. So this is my own interpretation of that data. But if you bifurcate the people in the clinical trial between those that are over 65 and under 65, the under 65 groups, you would need to treat more patients, 13 patients, to prevent one discontinuation due to an adverse effect. Whereas in older patients, if you treated 9 patients, you would prevent one adverse effect. So maybe that might be, but still a number needed to treat of 9 doesn't seem very appealing for such an expensive therapy. Another poster that I saw presented was about low body weight, trying to, again, increasing the risk of leukopenia in patients on valganciclovir. And so your odds of leukopenia increased by 1.7 for every 1 kilogram decrease in your body weight. So essentially, lower body weight patients had a higher risk of neutropenia or leukopenia. So another study kind of digging into this topic was this poster presented by the group at NYU. And they demonstrated that patients who developed neutropenia while on valganciclovir do have a higher incidence of infections and rejections. And so, if you're on Valsite, you get neutropenic, that portends other badness for you. It's not like a benign adverse effect. There's like other related adverse effects that come along with that. And so, is that related to, is that a modifiable risk factor? We don't know. So can reducing that rate of neutropenia by using alternative strategies or agents modify that risk? That's the unknown part at this point, because the clinical trial that we have was not designed to study any of these endpoints that are unrelated to CMV. There was also, talk about maribavir. So maribavir, is approved for resistant refractory CMV in SOT recipients, and Emory presented their real-world experience with using this drug outside of the clinical trial setting. And they had a cohort of 10 renal transplant patients, and the response rates were not as good as you might expect. 50% of them had what they considered durable virologic expression, 30% were non-responders, and 20% had an undetermined response. And there was a high rate of resistance. 2 of these 10 patients developed mutations. And so you can see on the graphs, the lower left is the viral kinetics of what it looks like if somebody actually responds to maribavir. So these were the 5 patients that responded. They had decreases in their viral load and resolution. But then on the right, you can see the non-responders, maybe had an initial decrease, but then an increase, a spike up in their viral load after an initial decrease. And then ultimately, many of these patients were switched back to valganciclovir, to other therapies. And so how do you appropriately use maribavir and manage this relatively low threshold for resistance? One presentation that I went to was from Dr. Raisonnable from Mayo Clinic, and he presented this treatment algorithm, which he had published in last year. And this publication, if you go read, is a very nice review of treatment of CMV in general and antivirals for CMV. And he proposes this algorithm for patients that have resistant or refractory CMV. And if they have resistant CMV, you tailor your antiviral treatment based off of their resistance profile, noting that maribavir does not have good CNS penetration. So if you're worried about CNS CMV, then you need to use a different agent. He also, indicated that in his practice for refractory CMV, he looks at the viral load. In patients with a high viral load, he says that he would initially treat with foscarnet for some period of time to reduce the viral load, and then switch them to maribavir. And so this is, I think, is an interesting approach. And there's also a lot of talk about other types of combination therapies, but we just don't have data on combinations of letermovir with other agents at this time, not prospective clinical data anyway. There's some talk about CMV T-cell immunity panels and how reliable this test is. And so some patients or some centers are trying to use this T-cell immunity panel to try to predict who's at risk for these recurrent or refractory CMV episodes, or late onset CMV. And so one setting that this test is being used in is at the end of primary prophylaxis. And my take home from this is that this is not a test you can necessarily hang your hat on. 3 centers presented kind of their experience, and they're somewhat similar. Rush said in patients with a positive TCIP that had their prophylaxis discontinued, 5 of 13 still had CMV reactivation or DNA anemia or infection after that. There was also UNC, which reported a rate of 4 out of 10 of their patients whose primary prophylaxis ended with a positive TCIP still had CMV DNA anemia above 500. And then at NYU, 2 of 11 patients with a positive TCIP had recurrence requiring treatment. So this is definitely not 100% in its ability to discriminate between those that are going to have a recurrence or not. Now, at the end of secondary prophylaxis, the test performance was better, and there was a very nice presentation by the group at UNC, presented by a pharmacist, that showed that there's increased predictive power when you combine this T-cell immunity panel with the ALC. And so if you had an ALC above 0.5, as well as good response on the immunity panel, you essentially had a 0 chance of CMV reactivation. And this is in the secondary prophylaxis scenario. So people that have already had, been placed back on prophylaxis, and now they're wondering about when to stop secondary prophylaxis. So that's one maybe clue of how this test might be clinically useful in the future. There's another study looking at this topic about that was in D+R- kidney transplant recipients that are evaluated with the T-cell immunity panel at 4 months. And so if they were negative at 4 months, they reduced their mycophenolate. I thought this was interesting. So they cut their mycophenolate in half or in a quarter, and then they rechecked it. So they're trying to see if by reduction in immunosuppression, they can improve the rates of immunity. But those that had a dose reduction versus those that didn't make any difference. It didn't improve their T-cell immunity panel, and there was also no difference in CMV infection rates or biopsy-proven acute rejection in those with or without a dose reduction. So this did not seem like an effective strategy to modify this. Here's my slide about Hep C, short duration, direct acting antivirals. And so there are several centers presenting on this. And so if you're in the transplant space, you know that HCV NAT positive donors are increasingly being utilized to expand the donor pool, but they generally require 8 to 12 weeks of DAA after you demonstrate infection. Several groups recorded success with shorter courses than that 8 to 12 weeks. And so like Mayo and Toronto are using just 8 days of DAA. It started pre-op in combination with ezetimibe. And VCU is using 7 days, again, started pre-op, and UCSD is using 7 days without the ezetimibe. And so, and all 3 of these centers report good success with these strategies. The key logistic challenge is who's going to pay for the antiviral, whether it's going to be your hospital budget, is it going to be part of the original hospital's DRG, or is it going to be billed to the patient's insurance? Obviously, being billed to the patient's insurance is better for the hospital's reimbursement. But on the other hand, you're exposing the patient to 8 to 12 weeks of therapy and potentially adverse effects, and there's potentially unreimbursed costs for coordination of that outpatient treatment. So it's kind of a tricky question to answer, but from the patient's best interest side, I think it's heavily skewed towards these shorter courses. And so it's something that I think all centers should be exploring, and take a look at these abstracts if you're curious at implementing something like this at your own center. So respiratory viruses and vaccinations were another topic of discussion. There's many people were presenting about a gap in the perception of vaccine utilization and the reality. So most transplant clinicians are familiar with the guidance and think that they're being utilized, but there's low rates of actual vaccination. And this is despite concurrent good data consistently being generated that COVID vaccines are effective. And this is one just abstract that highlights this, that shows the benefit with a reduced risk of death, intubation, and ARDS when vaccinated versus unvaccinated. And this is an SOTR specifically. And so this study from UCSD looked at their actual adherence rates to vaccines in their transplant population and noted a terrible overall adherence. Patients were only 12.4% had completed all their recommended vaccinations. And this highlights some of the gaps, like herpes. Zoster, for example, has one of the lowest rates of vaccination, despite recommendations that transplant recipients get this. In a survey that was presented in an abstract of 127 SOTRs about COVID-19 vaccinations, the top reasons that SOTRs reported getting vaccinated were for reasons of protecting their health, avoiding serious illness, and avoiding contracting COVID-19, protecting the health of their friends and family, and protecting the health of the community. So these are arguments that you can propose with your patients and motivational interviewing tactics to try to get them to accept vaccination. On the other hand, the top reasons SOTRs did not receive all the recommended vaccines says they do not think it's effective. So it's an education issue. 21% thinks it is not effective. But that slide that I just presented on the previous screen, I think convincingly shows that these are effective. Other reasons, including side effects, a concern about an interaction with the immune system or transplant, finding time, not thinking it's necessary. And these are all questions that we need to address if we're going to improve vaccination rates, both with the COVID vaccine and other vaccines. In a podium presentation, Johns Hopkins presented data in RSV vaccine responses among SOTR. So we know that the new RSV vaccines were approved last year, but up until now, we did not know how SOTRs did with those. And so they demonstrated that they did have a response, that there is an increase in anti-RSV antibodies in those patients that were vaccinated. It is not the same as in healthy people, and a quarter of them did not achieve a full change of their antibody levels more than 4 weeks, which is considered in the industry a marker of vaccine response, and less than 50% greater than the pre-vaccine high titer plasma. So so if you had previous RSV, you maybe had better response than getting the vaccination, but there's still some good response. So there was a trend towards higher peak responses with the adjuvanted RSV vaccines made by GSK. And there may be a benefit of repeat vaccination in select individuals because there are some discordant IgG and IgM responses showing some only developed an IgG response without a durable IgM response. And you want the IgM response for a vaccine. And so we don't know the durability of this vaccine beyond 3 months. We don't know the efficacy in SOTRs. These are all studies still to be done. All right, and then just a couple slides on liver transplant. So I found this poster from UIC looking at AKI after OLT. I thought this was a nice little succinct study, well done, looking at just basic risk factors, because we often have the question of like who should be getting renal sparing immunosuppression. How can you predict AKI before it happens? And in their analysis, the presence of non-alcoholic fatty liver disease or a high BMI were heavily predictive of AKI, and protective factors included being taller and having a higher albumin. So maybe some markers of how quote unquote robust you are going into the surgery, as one of my surgeons always likes to say, is how robust are you? And she has this kind of eyeball test from the surgeon's perspective of who she thinks is going to develop AKI. But it's nice to have some data to back up our eyeball tests. All right, here's another slide about chronic suppressive antibiotic therapy. I don't know if you've ever done this. If you have a patient with recurrent cholangitis, they've been admitted multiple times. Sometimes the topic comes up, oh, should we put them on suppressive antibiotics to help prevent them from being readmitted constantly? These are patients with like ischemic cholangiopathy, with recurrent cholangitis, and I've definitely seen this in practice. I've done it in practice, but I didn't know that there was any data to support this. It's nice that Toronto has now published a large cohort of patients where they followed them and they demonstrated good effectiveness with no major adverse effects with suppressive antibiotics, and moxifloxacin was kind of their go-to in this study. All right, so I'll take a few moments to just pause on the references so they're captured by the recording. It was like drinking from a fire hose being at ATC, and you probably felt the same way listening to me try to summarize what I found interesting in just 15 minutes. And so these are the references. I'd encourage you to dig into these. There's a lot more that I couldn't present in this time that you can learn from reading these abstracts and talking with the presenters. And so with that, I'll open it up for questions. I do see one in the chat here. It says, for HCV positive organ kidney donors to HCV negative recipients, are there any new information on potential FDA approval for prophylactic treatment of HCV for this patient population? Yes, that would be great. If we had FDA approval, it would certainly support our argument for getting it on formulary. But yeah, I do not know that any of these centers are pursuing this as like a labeled indication for the drug. None of these protocols that I was I had presented on, to my knowledge, were industry funded or conducted in a way that would be acceptable, I think, to the FDA to support a new indication. So I don't know. I don't know that that's coming. I don't think that the company is interested in our small little pot of money when they have several hundreds of $1,000s that they're making in the general population.
Agreed. Thank you, everyone. Those were some great presentations. Again, I'll open it up to any other questions in the chat. I don't see any others, but feel free to add. We do have a few more minutes, so please send over any questions. While waiting for those extra questions, I have a question for Evan. I was wondering, one, did you sleep well at ATC? And two, I saw you mention your poster really briefly. I was wondering if you could tell us more about your what you guys did as far as like outpatient management of COVID and how you decided what patients should get for outpatient management.
Sure, yeah. I slept little, but on my poster, yeah. So we, UW, you can kind of see it there in the corner, had a treatment algorithm where we, left it up to the providers to decide, okay, should they get referred to the pharmacist for Paxlovid treatment, or should they get IV remdesivir? And if they couldn't access IV remdesivir, then they would get molnupiravir. So it's sort of a tiered treatment strategy. And we presented outcomes on this. Turns out in our provider group, they were very hesitant to entrust the pharmacist with the Paxlovid. We had a couple oops Paxlovid cases in our at our center prior to the development of this protocol. And so we just had a lot of cold feet from our providers. And so we ended up only having like 2 patients treated, or I think 3 with Paxlovid. So, but we had well over 100 patients. There was 200 plus patients on this presentation that I presented, most of whom were treated with either REM for 3 days, REM for 1 day followed by molnupiravir, or molnupiravir times 5 days. Comparing the patients that received preferred therapy versus those that received quote unquote non-preferred therapy or less than ideal therapy, i.e. molnupiravir alone, those patients did similarly well, at least in our study. The overall hospitalization rate or treatment failure rate for these mild to moderate COVID patients was still hovering around 4 to 5%, which I find is still quite high. I think it's really important that patients still know that there is risk of hospitalization. Luckily, none of our patients in our treated cohort died or required ICU stays. So that tells me that our treatments are effective. It doesn't, and it takes several different treatment options in order to have good access to treatment. We were able to treat the vast majority of patients that were referred. Only a small sliver of patients flat out refused therapy. And most of those were cases that, either their symptoms were improving at the time that we reached out to them, they were beyond the symptom window, or there was some other like logistic barrier where they just couldn't get here. But, there were like only 12 patients that didn't get therapy out of 200 something, so less than 10% of patients we didn't get access to therapy. The other finding from my poster that I'd emphasize is lung transplant patients do a lot worse than other transplant recipients in terms of COVID. If they have mild to moderate COVID, even with treatment, their rate of hospitalization was about 20%. So they were much more likely to be hospitalized within 30 days, even after getting like 3 days of REM or a day of REM and molnupiravir. Now, the reason we did this 1 day of REM and molnupiravir was just because of infusion center access. There was a period of time early in our treatment algorithm where we didn't have 7-day-a-week coverage for the infusion center. So we could only cover 4 days a week. So, and it was like Monday, Tuesday, Thursday, Friday. So it was literally impossible to get people in infusion on Wednesday or the weekend.
Right.
So we couldn't do 3 days of RIM. So you had to do 1 day of RIM and mol. So anyway, I could talk a lot more about that, but I'll leave it open for other questions if there's any.
Interesting. Yeah, thank you. I don't have any other questions in the chat. I think we'll end it a few minutes early. Thank you again to our wonderful speakers and for sharing all of the knowledge you learned in those few days at ATC. I'm sure those of us who weren't able to attend really appreciate the little overview you were able to provide. So thanks everyone for joining. And again, we will be uploading the recording to YouTube within the next couple of months.